She's an associate professor of neurology, family medicine, geriatric primary care physician, and clinical research investigator for the Goizueta, am I saying it right? Goizueta
That's correct.
Alzheimer's Disease Research Center at Emory University. She's the outreach, recruitment, and engagement core lead for the Goizueta ADRC and responsible for creating and implementing community programming, education about healthy aging, Alzheimer's related diseases, and representation of the ADRC clinical neurological research enrollment. So all very compelling topics for me personally and for our study. We believe this will have great universal relatability, and we know you've received many honors throughout your career. So we just are very grateful to have you here, and we'd like to get started. I'm going to mute and hide myself, but I will be able to hear you and advance your slides as you wish. And I also did post where questions can be asked, and we'll address those at the end. So thank you very much, and welcome, Dr. Parker.
Well, thank you, Ms. Penziner. I hope I said your name correctly. And thank you for all who are joining us today. I was asked to talk about the overlap between chronic illness and cognition. And this is kind of part of what my, I call it my last chapter of my career is. And what is important for most people is to understand that a lot of the everyday chronic illnesses that affect many of us, almost all of us over the age of 60 and 65, have a direct effect on how good or bad your cognitive health will be. So let's dive in right here. Next. My disclosures, these are my current funding sources. I'm funded by NIH, NIA grants, as well as philanthropic organization, the Alzheimer's Foundation of America. And I have done external consulting and received program funding from Biogen, Eisai, Eli Lilly, and Genentech. Next. Our objectives today are 1, to explain and illustrate how clinical care access affects the diagnosis of neurocognitive disorders, illustrate what the Georgia state plan is for Alzheimer's disease and related dementia diagnosis, and finally, define the approach for the participation of understudied populations in ADRD research at the Goizueta Alzheimer's Disease Research Center. Next. So I have in front of you a snapshot of health in the United States. I'd given a version of this talk a little earlier, a couple of months ago in Indiana. And one of the things that's really important to know is that healthcare, we're all aware that healthcare access and healthcare provision is not the same for everyone. Nearly 50% of the United States residents have no health insurance and are mostly people of color. The life expectancy of Native Americans and Alaska Natives is 5.5 years less than all others. This comes from the Disparities Fact Sheet. Cardiovascular disease comprises 40% of the difference in life expectancy between African Americans and whites. More than 77% of Latino adults are overweight or obese, compared to 67% of white adults. Women have a 9% higher mortality rate after an MI or stroke than men. And finally, only 70% of persons identified as LGBTQ adults seek healthcare services or have a regular access to a regular healthcare provider, compared to 90% of heterosexuals in the United States. Next. So we're here to talk about neurocognitive disorders. So for many on this call, you're familiar that there are many different neurocognitive syndromes and diagnoses. The most commonly diagnosed neurocognitive disorder is Alzheimer's disease, followed by a vascular dementia, followed by mixed dementia. And then there are other illnesses that have other names, things like dementia with Lewy bodies, Parkinsonism, or Parkinson's dementia, frontotemporal dementia. One of the things that we've learned in our Alzheimer's autopsy groups of patients that have participated in our research is that in some of the older people, there's not necessarily discrete Alzheimer's or discrete dementia body with Lewy bodies. There's frequently pathology associated with multiple different neurodegenerative disorders. What are some of the clinical things that contribute to a diagnosis of dementia or neurocognitive disorders, which is what the preferred terms are? Vitamin deficiencies, thyroid conditions, depression, medication, over medication or polypharmacy, chronic alcoholism or substance abuse of other things, concussions, head injuries, and delirium, which results from a chronic and acute exacerbation of a medical problem that needs to be addressed. Next. So there are things that we know that put us at risk for dementia, and many of those things are modifiable. This comes from the Lancet Commission report. So what are those things that are modifiable? Depression because we can diagnose it, and more importantly, there's a treatment for it. Alcohol abuse, exposure to air pollution, hearing impairment, and newest out is visual impairment as well, obesity, diabetes, head trauma, lack of education. That doesn't mean you need to get a PhD. You just need to be literate enough to interpret medical literature and health information. Chronic illnesses like hypertension, cardiovascular disease, COPD, anemia, physical inactivity, lack of social contact and social isolation, smoking, vitamin D deficiencies, vitamin B deficiencies, sexually transmitted diseases. And I put that on there because tertiary syphilis manifests with neurocognitive symptoms, as does advanced HIV infection. Next. This is a graphic that comes from the Lancet Commission report that was reissued in 2024, initially offered in 2017. These are the different modifiable risk factors that are responsible for lots of dementia. All the things that I mentioned previously we start looking at Alzheimer's and related dementias or neurocognitive disorders as a spectrum of disorders that basically start with the way you started out. So early life risk factors, the environment in which you are born, whether it's full of pollution, lack of education, progressing through midlife. And I just went through the list of things that people are treated for, but in midlife, in your 40s, in your 50s, we need to start paying attention to these different illnesses, hypercholesterolemia, depression, screening for those things. Then in later life, as people get a little older, their social contacts change, and the more limited social contact you have, the more likely you are to develop symptoms that may go along with Alzheimer's. These are the things that we can fix. The things that we cannot fix that put us at risk for neurocognitive disorders are things like age. We know that these disorders are more common in people who are over the age of 65 and living much longer. We also know that these disorders affect females disproportionately. Next. So here's a graphic that it kind of explains what affects your brain health. Health and nutrition. Consume a healthy diet. Now we're telling people we don't necessarily have a cure for Alzheimer's or related dementia, but we want you to practice a healthy lifestyle, keep your brain healthy. So we want you to eat healthfully. The more commonly prescribed diet for that has been the Mediterranean diet, but for simplicity's sake, for me and my patients, I say what's good for your heart is good for your health. So the American Heart Association recommendations for preventing hypertension fit for the healthy brain. Exercise. Used to say at least 30 minutes, 5 days a week, or 150 minutes a week. That exercise recommendation is going up to more like 200 minutes a week. Sleep. Getting adequate sleep, sleep disruptions, sleep disorders are tied to brain dysfunction. So if you have sleep apnea and you've been told to wear a CPAP, you need to wear that. But sleep is the time at which when it comes to Alzheimer's, our brain clears itself of amyloid or is allowed to regenerate and clear its brain. Brain stimulation, learning something new. We're lifetime students in medicine. We're always being recertified, taking quizzes, taking tests. And even if you're not a doctor, you need to do something that stimulates your brain and keeps your brain working. It's almost like a car. You have to have regular tune-ups and keep it busy so that it runs properly. Social interactions. People who are socially engaged have better cognitive function and longevity than people who don't. And then finally, mood disorders. In older adults, frequently undertreated, underrecognized, and undertreated are things that are diagnoses of depression and anxiety. As part of the annual wellness exam, in addition to doing a memory screen like a mini cog or a MOCA, we advocate that you get an anxiety screen as well as a depression screen. Any doctor who's doing this has their own favorite tools, but these are the different elements that affect brain health: nutrition, diet, physical activity, social connection, mood disorders, being stimulated, and getting proper sleep, enough sleep. Next. Here at Emory and across the country, beginning with a study, we have a study called Superagers. These are people who are over the age of 80 who still function and act much like they did when they were in their 50s. What are some of the things that contribute to successful aging? Well, 18% still work after their formal age of retirement. Formal retirement is 68.5 years of age, not 65. And 87% of those persons who age healthfully are physically active and physically engaged. Next. Here in Georgia, these are some statistics that come from our Georgia Department of Public Health. And I'm proud to say that Georgia is a state, unlike many others, that actually has a state plan to try to address some of the disparities with respect to getting a formal evaluation for cognitive dysfunction. Here in Georgia, we estimate there are about almost 200,000 people with Alzheimer's or related dementia as of 2024. 28.5% of the entire Georgia population had no doctor or healthcare access point. And if they did have healthcare access, it likely didn't come from a doctor. It came from the Georgia Public Health Department. 19% of Georgia adults could not visit a doctor. Lots of reasons for this, but I think most commonly that there isn't a doctor available. 50% of all Georgia Medicare beneficiaries have multiple chronic diseases. 90% of those persons who've been diagnosed with Alzheimer's or related dementia have multiple chronic comorbid conditions. These multi-comorbid conditions include things like high blood pressure, type 2 diabetes, chronic obstructive pulmonary disease, chronic kidney disease, cardiovascular disease. And under this, I want you to put things like stroke, atrial fibrillation, congestive heart failure, chronic anemia, and rheumatoid arthritis. By comparison, persons who don't have a diagnosis of Alzheimer's or related dementia have one or no chronic comorbid conditions. I should say they should be under control too. Next. So, if you're having or experiencing trouble with your memory, do you shoot straight to a neurologist? Where do you go? Well, most people will start with their primary care doctor. Most people, depending upon where you are, because I've been in an academic setting, it's not been difficult to refer my patients to specialists who can complete a very formal and very thorough evaluation for cognitive disorders. But most people follow up and see patients in the primary care setting. They may be followed by a geriatric provider. And then the persons who are less likely to be seen for cognitive dysfunction, simply because it's a referral process and because they're not available, may be a memory disorders clinic or other general neurologist clinic. People who are diagnosed with mild cognitive impairment have the same kind of evaluation or have the same access points for evaluation as do people with Alzheimer's or related dementia. Common to both of them is the fact that most of them will start out with their primary care provider for evaluation, which makes it important for primary care doctors to have access to the right testing skills and resources to make a proper evaluation. Doesn't mean they don't have the skill set, they just may not have the tools in their community. Next. Here in Georgia, we have something called the Georgia Memory Net. So there are now 7 different clinics serving 159 counties in Georgia. And these Memory Net, Georgia Memory Net assessment sites are in areas that are areas with a high deprivation index, but also looking at the southeast and southwest corners of the state, areas where there are very few providers, medical providers, primary care providers of any sort. I'm in Atlanta, the Atlanta region. Yes, we have Emory University there, but there are still people being seen by providers or in systems that don't necessarily have neurologic expertise available. Next. In the Georgia Memory Net, the way it works is primary care providers seeing patients, recognizing that these people are exhibiting signs and symptoms of dementia who need further evaluation, are sent to one of these memory assessment sites with a completed medical evaluation, i.e., recent doctor visit, updating their medications, updating their laboratories, and with an MRI, a current MRI if one is available. On the right-hand side, you see the patients in general Georgia population who receive an annual wellness visit. And as part of this annual wellness visit, you do get a memory screen and an anxiety screen. In the general population of Atlanta, 54.3% of non-Hispanic whites receive an annual wellness visit. By comparison, 31% of African American people will receive an annual wellness visit. People who are referred to a Georgia Memory Net will receive an annual wellness visit and other things that go along with getting an assessment for ADRD. Next. In these primary care, they're really primary care centers, the people who are conducting the more definitive neurologic assessments in these memory assessment centers are primary care doctors. Some of them may be neurologists, but they're regionally based neurologists, but they're in active primary care practices where specialty care is more likely. So I live in the Metro Atlanta area, and you can see what the diagnoses are of many of our patients being seen in these different centers. Most of the people who have been evaluated for ADRD do have a diagnosis of mild cognitive impairment, and they are undergoing further evaluation for other risk factors. Quite a few people, depending upon where you are, in the purple stripe, have what we call vascular dementia. And that's a dementia that's associated with hypertension, diabetes, high cholesterol, any kind of cardiovascular illness. Next. In our research center, this is our kind of like mission statement and what our objective is. And because a lot of the people, because we want our research population sample to be representative of the Metro Atlanta population, it's not necessarily a population that populates the Emory healthcare system or comes to the Emory clinics that are in an academic-based practice. So for that reason, a lot of the outreach work that I do involves patients who have providers who are not Emory healthcare, Emory faculty clinicians. They are seen in other health systems to include things like Kaiser Permanente. They may see Piedmont is one of our healthcare systems, a WellStar system, the VA system even. But a lot of the participants in our research here at our Goizueta Alzheimer's Disease Research Center are not necessarily Emory healthcare patients. Next. So I do what we call an educational outreach, and that educational outreach allows me to address the health issues that may affect many of our patients, regardless of your ethnicity or your gender. So we try to talk about and focus on what makes you healthy as you age, what makes a healthy brain. So depending upon what the audience wants or what the population or community wants, we kind of deliver that to them. They want to talk on heart disease, we talk about heart disease. And we talk about how heart disease affects the brain. If it's somebody who has is interested in endocrine disorders, things like thyroid disease and diabetes, we try to talk about those disorders, what can make them better, and how you need to screen and monitor for them, but more importantly, how they do affect your brain health. So depending upon who the organization is or who it is we're working with, we work with them to develop a program that answers and addresses the medical issues that they want addressed, and then also allows us to answer questions about, or I shouldn't say answer questions, I should say gives us the opportunity to discuss research options that are available in our Alzheimer's Disease Research Center. Emory Goizueta's Alzheimer's Disease Research Center is one of 37 such centers funded by the National Institutes of Health and National Institute of Aging in the United States. So here I focus on the research studies that we have. Every center has several studies in common, but there are several others that are different. Here in Atlanta, because we are aligned in the research community with both Georgia Tech and Georgia State universities, we have more people involved in aging research. Aging research with Georgia Tech may involve something like learning about devices that we can use. As an example, for our Alzheimer's research, two of the things that I know that are being worked on at Georgia Tech are using earbuds or ear devices to do sleep studies. I mentioned in some of our prevention studies, our prevention risk factor reduction, sleep is important. Measuring that sleep can be a challenge if you have to come into a facility to get a sleep study. So Georgia Tech is developing a technology where you don't have to come in, but you could put monitors on your ears or sensors on your ears to do that. Just about everything that you have learned that helps aid aging, technology, packaging, and other things, that kind of research, and even home design, kitchen home design, is being done at Georgia Tech, and they have studies. And if people are interested in that, we can make people who come to our programs aware of that. Frequently, a lot of the providers or the investigators who are doing research studies at Georgia Tech, Georgia State, Emory, Morehouse, are speakers in our different programs, and they can come and talk about what their studies do and how it improves things. So we work with people to tell them what's available, how they can get involved. And we like to make sure that providers, medical providers, whether it's a sleep doctor, a lung doctor, or a lung specialist, or a heart doctor, comes to talk about these disorders and their specific studies. So in this way, we're able to try to inform the population that comes about what they can do to stay healthy and give them a way to access a medical provider and or a research study that's of interest to them. Yes, we have clinicaltrials.gov, but locally, it's a lot easier to just say, well, these are the studies we have here. These are some of the studies you might be interested in. Next. We have some standard programming. We have a weekly webinar where we feature a number of different specialists from all over the country to talk about health and aging and Alzheimer's and other dementias and resources. We have a monthly men's health discussion group where men come and women are not allowed. to talk about things that are of interest to them that affect their health. And we have a special monthly men's discussion group because men are less likely to monitor their health, I should say that, in the way that they should, but they're also a demographic that's sorely missing in research clinical trials, particularly men of color. We do twice a year brain health aging forums at the Carter Center Library or Chapel. And every month we have several programs that we do throughout the community in partnership with service organizations, churches, civic groups who want to know more about aging. These are opportunities to talk about health and aging and how these things affect your overall health and affect your brain subsequently. But these are also opportunities for us, again, to talk about research. And one of the things I'm really proud of now is Atlanta is the site of something called the Neuro Arts Initiative. There's a big movement in the country trying to connect arts engagement with improving brain health and cognition. We've been funded through the Alzheimer's Foundation of America to study how attending the symphony may help improve mood and behavior and or cognitive function for people living with cognitive impairment and their family caregivers. We've gotten the funding and we're working on the project, and I'll let you know how that works out in the next couple of years, but it's part of a big neuro arts initiative to determine what features in the arts community, whether it's the visual arts, the performing arts, or symphonies, what works and what works for whom, how it works. We talk about there's benefit, but we don't really know what dose and how much. So that's something we're working on. Next. This is a flyer for our most recent Brain Health Forum. And the feature was talking about Lewy body dementia and early onset dementia, as well as psychiatric syndromes or psychiatric problems that manifest as a dementing disorder. And we did have one of our faculty from Georgia State talking about the ethics and the importance of research participation and what the challenges are for somebody who's been diagnosed with early onset dementia. Next. We recently published a paper here about our outreach work, and we looked at the number of programs that we did in a certain period of time, trying to see who came and what motivated them or how they got involved in or when they got involved in research. That's the important piece. And what we learned is that men are more easily persuaded to participate in research without too much fanfare. If you give them the information, they kind of sign up. Women take a little bit more time, but the people who showed the most, let me put it this way, it took a whole lot less energy to engage a man and get him consented to research than it did anybody female. Next, keep going. People of color were more likely to attend community education events versus persons who weren't. This particular graph, this violin graph, if you will, shows that men were more likely to attend an event and soon after had a shorter period of time between when they went to a program and when they actually enrolled in research. That's the important thing. Next. And that paper was just published in the Alzheimer's Journal of Alzheimer's Disease last month, actually. One of the successes that we are really proud of is that our longitudinal cohort for participants in research demographically reflect the population in Atlanta. Our autopsy rates in terms of who donates their brains for further science African Americans rate of autopsy was 63% versus 67% for all participants or non-Hispanic whites. We have participants of color, particularly African Americans, who participate in more than one study and donate multiple biospecimens, whether it's cerebrospinal fluid, MRI, saliva. They participate in anything. Many of our participant biospecimens support multi-center trials all over the country. We're in a project with University of Wisconsin, George Washington, University of Pennsylvania, and we're getting ready. I mean, I think that's universal in Alzheimer's disease research centers across the country, cross collaboration with many studies, in addition to most of the longitudinal studies that are common to all of our centers. The Alzheimer's Disease Neuro Initiative, which is a 20-year study looking at radiologic biomarkers, we have exceeded the number of African American or Black participants when compared to other sites. Next. In summary, it's important to appreciate that comorbid conditions do affect cognitive health. And when it comes to research, if you have an unmanaged chronic illness, you're not a good candidate for cognitive research. And it's really important for all persons to manage any of their chronic conditions to the best of their abilities, simply because this prevents the sequelae of unmanaged health, and it does have an effect on how well your brain works. And for us, addressing issues of chronic health do act as kind of a lever to drive people into our Alzheimer's research, which is mainly focused right now on preventive strategies and preventive measures. People who have been received a definitive diagnosis of a neurodegenerative process are able to be in clinical trials, but you can't clinical drug intervention trials. Let me be more specific. But unless you have a full diagnosis, you are not able to be in those interventional treatment trials. If you don't have clinical care access, you're not necessarily able to manage chronic conditions, and you're probably not able to access the specialty evaluations and care that's required for evaluating and diagnosing people with Alzheimer's or related dementia. And Alzheimer's disease research enrollment and participation is greatly affected by one's overall health, and more importantly, and this is one of the problems, access and knowledge of the opportunity to participate in research. People who screen fail, which means they're determined ineligible for certain studies, usually do so because they have an unmanaged chronic condition, and they otherwise don't meet eligibility criteria for participation, mainly because they have an unmanaged health issue that needs to be addressed. And with that, I'm available for questions.
Thank you so very much. That was wonderful. I'm going to open up my panel where the questions are listed, and we'll get those posted in just a moment.
Will I be able to see them?
I'm going to read them aloud. Yeah.
Okay.
So the first one we are asking is, what is the relationship, if any, between Alzheimer's disease and CADASIL?
Okay. I think that one of the things that's important there with on brain MRIs, for example, that's a real significant, you have lots of white matter change. And if you don't necessarily know, if you're in a place where you're not diagnosing and seeing these things, you're not going to necessarily get the connection. But most people with how do I say that? Most people who have that have other cardiovascular conditions, more leukocariosis, more white matter hypertensities, more evidence of brain dysfunction.
Thank you. I would like to ask the next question about some of the achievements that you mentioned with regard to balanced representation and recruitment. And I wonder if that is contributed or, succeeded because of the reputation of your institute, or do you have any advice for maybe smaller studies that are trying to achieve that?
Well, I think we make a concentrated effort to engage different populations within our community. As I did mention in my presentation, many of the patients that are being seen in the Emory healthcare system are largely patients who have health insurance. And within the Emory healthcare system, if you're seen by the primary care clinic, there's kind of like a direct path or that you can follow that allows you to get referred into the neurology department for a neurologic evaluation. For people outside of Emory healthcare, whatever system is available in your respective communities, that's where you go for your evaluations. But as I pointed out, many of our patients who are from different communities of color are not necessarily Emory healthcare patients. So we do programming specifically for a community. So we go into the Latin American community through the Latin American Council or through community centers that are serving a specific population. So we're reaching out to the Asian American community, and they are in throughout Metro Atlanta, but they have providers that serve their population specifically, and they have community centers. So when you reach out to those providers in those communities, we have a program with them and help them kind of give you a menu, if you will, of what you can do in order to access programs. And I brought up the Georgia Memory Net because many of these providers and populations are outside of the Emory healthcare system. So, and they may or may not have a neurology group within their system that does these kinds of evaluations. So we help them get access to the Georgia Memory Net, where the kind of evaluation that is done at Emory is done in these memory assessment sites. So most people are referred in with a medical record or history of medications and an MRI from their provider. But if they aren't able to get one when they come to one of the memory assessment sites, and we have telemedicine sites through the Georgia Department of Public Health, we arrange for them to get that MRI and bring them in for a more definitive cognitive assessment, neuropsychiatric or neuropsychologic examination, and a lumbar puncture, where they can have cerebrospinal fluid drawn. In these centers, they diagnostically, in order to be on the disease modifying therapies, the lecanemab and the donanemab, those infusions, you have to have a definitive diagnosis of Alzheimer's. And in order to get that, you must prove that you have Alzheimer's by getting CSF confirmation or PET scan confirmation. Some patients in our research population have had a PET scan, and now that Medicare pays for it, more people are able to get them, but they're not what PET scans are not widely available. So the answer to the question is, as a provider, providers go into the communities with us and talk about whatever it is that community asks for. And that's where we talk to them about all the things that I've spoken about before. What promotes healthy aging? What's good for your brain? What is it that we need to do? How do I get an evaluation? Okay, I want to participate in research. How do I do that? So we have providers in addition to or aside from myself who actually go and give talks in these communities to the populations that are targeted.
Thank you. That's great outreach and a great example of giving back so that it's a two-way dialogue as opposed to just a recruitment process. And then we have another question here. It says, thank you for your work in addressing health issues for the population. Interesting to see vitamin D deficiency is a risk factor for cognitive decline. My partner who has CADASIL was prescribed vitamin D. Can you explain what the connection is between brain health and vitamin D?
I can't explain it in great detail, but in addition to vitamin D, vitamin B, B12 deficiencies are associated with brain dysfunction. And all I can say is to some degree that is something that has to do with the neural biology, the actual nerve, keeping your nerves healthy. That sounds too simplistic, I know, but having a B12 or a vitamin D deficiency are things that are fixable and makes whatever the deterioration is less likely. So in a dementia evaluation, we're going to measure a B12 level. We're going to measure a vitamin D as in dog level. Some doctors get a homocysteine level. I don't, but I always get a B12. I always get a vitamin D. Why? Because those are things that can fix something. If somebody's got a deficiency and that's contributing to some dysfunction, you fix the deficiency, you may improve something for that individual. So those are things that we look at. Same thing with thyroid disorders. I can't explain the mechanism, but I do know that they are associated, and as part of our evaluation and workup, we do measure those levels and fix those deficiencies or work to fix them.
Thank you. This may be somewhat related. This next question says, I follow good health approaches, careful diet, exercise, social community engagement. I work a limited but regular amount of hours, but I was under the impression that we cannot reverse CADASIL-related cognitive declines. How might we interpret and apply these findings for benefit?
I think
So,
what I was
sorry.
trying to get at really is prevention. And no neurodegenerative process is reversible. And the idea is to do everything you can to prevent something. And when it comes to CADASIL in particular, those processes like Alzheimer's, they start many years ahead of time. So all of the things that I mentioned that are associated with CADASIL have some preventive aspects. You're not born with it.
Thank you so much. I think that is our last question. And we greatly value your time and your expertise. With our greatest thanks for sharing with us, and hope we can stay in touch. I'd like to reach out to you in the future and talk a little bit more about the recruitment process and our own efforts to enhance representation. So thank you so much for being here, and any final comments or things that you wish to share. Otherwise, I will close our meeting and look forward to seeing everybody next month for our webinar in March.
Well, I think the main thing that I did want to get across is that you will be given these diagnoses. Okay, CADASIL has a genetic component, significant genetic component. So does Alzheimer's. So does what's the other one? Certain early onset Alzheimer's, early onset dementias. There is a genetic component. And you do inherit a lot of these things, but there are other things that go along that can make all of these conditions worse. And so what we're working with in research is what can we do to minimize the effects on neurodegenerative development, disease development. And so, no, you can't change your genetics, but you can certainly help things. So all of the things that I mentioned are things that all of us should pay attention to in terms of aging. And there's not really enough research to say A connects directly to C, to D, etc. But we are finding that lifestyle does improve and help us maintain our cognitive function over time. Nothing reverses neurodegenerative disease, but there are things we can do that can prolong our independence and our independent functioning. And those are the things that we should concentrate on. I hope that helps.
Does. Thank you so kindly. Thank you very much, everybody. Thank you also for your great questions and for joining us. We'll see you for the next webinar next month, March 24th. Have a great evening, everybody.